Okay, VQ mismatch is a critical concept for the boards, and we've already alluded to it a couple times during this talk. In this concept, V equals ventilation while Q stands for perfusion. The ideal situation is that ventilation is perfectly matched to perfusion, and thus you get a VQ ratio of 1. So what happens in the typical person? Well, the average person maintains 4 liter of ventilation for about every 5 liter of blood flow, giving an overall VQ ratio of 0.8. However, in the lung of a standing person, there's variation in the VQ ratio thanks to gravity. Basically, ventilation relative to perfusion is greater at the apex of the lung, so you can get wasted ventilation, while perfusion is at a maximum at the base of the lung, where you can get wasted perfusion. Again, as you can see in this diagram here, perfusion is a function of the interplay between the pulmonary arterial pressure, pulmonary venous pressure, and the alveolar air pressure. It is worth noting, however, that both absolute ventilation and absolute perfusion are greater at the base of the lung than at the apex. However, gravity increases perfusion more than ventilation at the bases. And at the apex, the wasted ventilation is a reason why certain bugs like TB tend to end up there. Now let's talk about the extremes of VQ mismatch. A VQ of 0 represents a complete shunt in which there is no ventilation for perfusion. So what are some examples of this? Well, you can see this shunt with status asthmaticus and airway obstruction. And in these cases, increasing oxygen availability does not really improve arterial PO2. What about the opposite scenario? Here you have dead space ventilation representing a VQ mismatch approaching infinity. In other words, you've got ventilation without perfusion, so basically Q equals 0. So what's a clinical example? Well, a massive PE would be the classic example here. In this case, giving the patient 100% oxygen should improve PO2, except the blood's not really going anywhere. So far, we've talked quite a bit about the role of oxygen in pulmonary physiology. Just as important, however, are the mechanics of carbon dioxide exchange. From the acid-base physiology material in the first aid renal physiology section, you'll remember how the lungs and kidney work together to maintain homeostasis in the human body. Carbon dioxide is transported from the tissue to the lungs in 3 forms. The vast majority of CO2 is found as bicarbonate, which is this. The remainder is either bound to hemoglobin, favoring which form of hemoglobin? The taut form of hemoglobin. And finally, it's also found as dissolved CO2. Now, CO2 is involved in 2 rather complicated but important concepts in respiratory physiology. One is the Haldane effect, and the other is the Bohr effect. The Haldane effect describes the phenomenon in which carbon dioxide is released from red blood cells. In the lungs, oxygenation of hemoglobin causes dissociation of hydrogen ions, which you can see here and here, which can then combine with bicarbonate to form carbonic acid. So why is that important? Well, the bicarb is ionic, so it can't pass through the cell membrane. But when carbonic acid is converted to CO2 and water, carbon dioxide and water by carbonic anhydrase, these small uncharged particles can freely cross the cell membrane. So the overall effect is that the greater presence of oxygen in the pulmonary circulation causes carbon dioxide to be released, and it can subsequently diffuse into the alveoli and then therefore be exhaled. And as we alluded to earlier, the Bohr effect is when the hydrogen ion concentration increases in metabolically active peripheral tissue and therefore shifts the oxygen hemoglobin dissociation curve to the right and favors the unloading of oxygen into the tissues. This topic is so high yield because the physiology is so clinically relevant and testable that it's something that could certainly show up on the exam. Alright, so you probably already know that athletes often train at high altitudes for better speed and endurance. You get increased minute ventilation as there is less oxygen content in the air at these higher altitudes. Gradually, the body adapts to altitude by producing more erythropoietin, which increases the hemoglobin and hematocrit in response to chronic hypoxia. And as we mentioned earlier, there's also an increase in 2,3-biphosphoglycerate, which does what again? Well, it decreases the affinity of hemoglobin for oxygen by stabilizing the T or taut form of hemoglobin, which promotes unloading of the oxygen to the tissues, as you recall. At the cellular level, you see more mitochondria and the concentration of mitochondrial enzymes to improve the efficiency of cellular oxidation. Once you go from acute to chronic hyperventilation, you get a respiratory alkalosis, which is countered by an increase in renal excretion of bicarbonate. As you may remember from your first aid renal pharm section, we give what to treat acute mountain sickness? Yes, we give acetazolamide, and it works by forcing the kidney to waste bicarb. From a cardiovascular standpoint, chronic hypoxia leads to pulmonary vasoconstriction, and over the long run this can cause pulmonary hypertension and right ventricular hypertrophy. Finally, I've mostly talked about the chronic changes in the lungs, so I'll just mention that in addition to acute mountain sickness, a rapid increase in altitude can lead to pulmonary and cerebral edema, which is thought to be secondary to increased arterial and capillary pressures, as well as increased capillary permeability. Okay, so response to exercise is a moderately high yield topic that's worth reviewing at least once. So when you exercise, a number of things obviously happen. One, of course, use more O2, and of course you produce a CO2. Of course, the ventilation rate goes up to meet this increased oxygen demand, and more specifically, there's also an increase in both ventilation and perfusion. The VQ ratio from the apex to the basis of the lungs become more uniform, and this is mainly due to vasodilatation of the apical capillaries in response to exercise. As cardiac output increases, there's also a proportional increase in pulmonary blood flow to support more efficient exchange of oxygen and carbon dioxide. Interestingly, there's really no change in PaO2 or PaCO2 because of this increased ventilation, but there is an increase in venous carbon dioxide content. Finally, there's a decrease in pH because of the lactic acid. So what does this all do to the oxygen dissociation curve? Correct, it shifts it to the right. This allows the hemoglobin to unload the oxygen in the tissue where it's needed the most. Finally, what we discussed here not only applies to exercise, but can also be extrapolated to other situations in which the body is subjected to acute stress, such as during illness or after surgery.